Hello everyone, in this video we are going to take a look at iron deficiency anemia. So this is a specialized topic. So in the previous video we looked at anemia in general. Now in detail, the iron deficiency anemia. It is the most common type of anemia in pregnancy resulting from inadequate iron stores needed for maternal and fetal erythropoiesis. It is a significant public health concern, particularly in developing countries, due to increased nutritional demands during pregnancy. So, developing countries, not usually seen in developed ones. Causes. So, there is increased iron demand, inadequate iron intake, and increased blood loss, and there is also impaired iron absorption and chronic diseases and infections. So, these are the key headings which we need to write in the exams. Coming to increased iron demand. During pregnancy, iron requirements rise significantly for these particular things. Increased maternal red blood cell mass, fetal and placental development, iron loss during delivery. So these are the things for which we need to be ready. So iron requirements are needed for that, but in case they don't rise, in case the iron in case the iron supplementation doesn't rise according to the demands, there is iron deficiency anemia. So it increases by 15 milligram to 30 to 40 milligrams in pregnancy. So this is almost double, like more than double. So that is what we need to keep in mind, and increase the supplementation according to this level. And the next one being inadequate iron intake. So poor dietary habits, particularly low income settings, lead to iron deficiency, lack of iron consumption, reduced iron consumption, lack of iron rich foods like meat, fish, green leafy vegetables and legumes, and then phytates and oxalates in plant based diets inhibit iron absorption. So mainly this is a behavioral change that needs to happen, behavioral and socio-economic change to manage this. But the first one is they don't realize. Next one, increased blood loss. So heavy menstrual bleeding before pregnancy, repeated pregnancies at short intervals leading to depleted maternal iron stores, hookworm infestations or chronic parasitic infections causing slow but chronic blood loss. This one makes sense. Impaired iron absorption. Chronic conditions affecting iron absorptions include these things: hypochlorhydria, gastrointestinal infections, and celiac disease or inflammatory bowel diseases. So low stomach acid due to use of PPIs, H2 blockers. So we know that acidity is meaning decreased pH is necessary for iron absorption, but if that is not happening, that means iron is not getting absorbed. GI infections causing malabsorption, and celiac disease or inflammatory bowel disease leading to poor absorption of dietary iron. So these are the three things. Next, coming to chronic diseases and infections. Chronic infections like TB, malaria, HIV contribute to anemia by impairing erythropoiesis. Chronic kidney disease leads to inadequate erythropoietin production. Next, coming to effects of iron deficiency anemia in pregnancy. So there are maternal effects, fetal effects. We need to know both. And within maternal, we have during pregnancy, during labor, and during puerperium. So during pregnancy, increased risk of preeclampsia due to poor oxygenation, in intercurrent infection due to impaired immunity. This one makes sense. First one we need to go more in detail. Heart failure at 30 to 32 weeks, and then premature labor due to uteroplacental insufficiency. This one makes sense. So this one is this is seen even in normal people, wherein there is high output cardiac failure secondary to anemia. So that is something easy to remember. But this one, why mechanism in anemia. So let's try to understand. Leading to tissue hypoxia. So hemoglobin responsible for the transport. So it's the same mechanism like the previous ones. So preeclampsia, over there is lack of oxygenation, and because of that, shallow trophoblastic invasion and narrow high resistance spiral arteries. So that is the mechanism here, and overall it follows the same mechanism as the rest of the things in preeclampsia. So in case you have gone through the preeclampsia section, the chapter, it might be clear as to why so many things happen in preeclampsia. So this one is one of them, where poor tissue oxygenation leading to multiple other diseases, and the rest of the things we are clear. During labor, uterine inertia leading to prolonged labor. This is secondary to ineffective blood oxygenation. Postpartum hemorrhage due to poor uterine contraction. So both of them, if there is poor uterine contraction, there is PPH, and if there is PPH, there is anemia, and anemia can cause poor uterine contraction. So both can support each other. Vicious cycle. Cardiac failure due to increased strain on already anemic heart. So that is during labor. And during purpurium. So with this one I need to, I feel like I need to mention about it. So we have seen in this one, what is that, maternal changes in pregnancy, how there is rapid change especially during labor, what and all can happen. So that is something we need to keep in mind. So since so many variables exist, and especially during labor, lots of load on heart, already anemic heart can become problematic. And finally, coming to the purpurium, increased risk of sepsis, subinvolution and poor wound healing. Lactation failure due to inadequate nutrition and pulmonary embolism due to prolonged bed rest and thrombosis. So this is during purpurium. Now coming to fetal effects. Fetal growth restriction due to placental hypoxia, low birth weight and preterm birth, intrauterine fetal death and neonatal anemia, increase in the risk of infections and impaired cognitive development. So these things should be clear, because lack of oxygen can lead to so many other things, lead to so many other adverse effects. So we are done with the effects of iron deficiency anemia. Now coming to investigations. So thorough hematological and biochemical evaluation is required. So coming to the first one, CBC, then there are iron studies, then peripheral blood smear, then stool examination, and serum B12 and folate levels. So CBC, there is low hemoglobin less than 11 gram per deciliter, microcytic hypochromic anemia, and then low hematocrit. So overall, these are the features of iron deficiency anemia in general. Then iron studies: serum ferritin less than 30 microgram per liter, serum iron less than 60 microgram per liter, so doubling here, and then increased TIBC greater than 400 micrograms per deciliter. I have already mentioned it, anemia, but again, since there is increased capacity, what does increased capacity mean? There is decreased substrate. So substrate, what is the substrate? That is the iron. So this one is less, so this one correspondingly increases. Saturation percentage of TIBC less than 16%. So saturation of TIBC is less than 16%. 30, 60, greater than 400, less than 16. Coming to peripheral blood smear: macrocytosis, hypochromia, anisocytosis, poikilocytosis, and retic count is raised. Stool examination to rule out hookworm or chronic gastrointestinal blood loss. And then finally, serum vitamin B12 and folate levels to differentiate iron deficiency anemia from megaloblastic anemia. So these are the things we need to keep in mind for iron deficiency anemia. Very simple. Coming to treatment of iron deficiency anemia, management aims to correct anemia, replenishing iron stores and preventing complications. Now coming to specifically oral iron therapy, then we discuss parenteral iron therapy, then blood transfusion, dietary modifications, and finally prophylaxis. So one thing that I'd like to mention here is, in the previous video I mentioned ferrous sulfate being 100 milligrams daily. So that is somewhat different in this case. This is the correct one actually. Ferrous sulfate 200 to 300 milligram, that is the dose, and ferrous fumarate is 100 milligram. So this is something that I have changed in the previous question, previous answer. I have made ferrous sulfate as ferrous fumarate 100 milligrams daily. Something, if you don't know what I am trying to talk about, you will understand it more if you watch the previous video, anemia in pregnancy. Anyways, coming back, so we'll go through each and every one of them one by one. So first one, we have seen the dose, sulfate and fumarate. This one is 200 to 300, here it is 100. So one way to remember is fumarate in alphabetical order. This one is F, which is much earlier, and this one is S, which is much later in the alphabetical order. So first one gets 100, next one gets 200, 300, and then taken with vitamin C is ascorbic acid to enhance absorption. Should be continued for 3 to 4 months postpartum to replenish iron stores. So that is iron therapy. And then side effects: nausea, constipation, black stools, and alternatively we can use slow release iron preparations. So that is about oral iron therapy. Coming to parenteral, if oral therapy fails, we do parenteral, indicated in severe anemia, malabsorption syndromes, intolerance to oral iron. Severe anemia less than 8 grams per deciliter in last trimester, malabsorption syndromes, intolerance to oral iron. And options include iron sucrose, ferric carboxymaltose, and iron dextrin. So these things we know, right? These particular, in case you are not able to feed, this thing doesn't go inside properly, inability to absorb fast. Like we need to raise the iron levels very fast in severe anemia in this particular case, and this thing, it is not getting absorbed properly, and in this particular case you can't tolerate it, meaning some taste buds. Yeah, so in those particular cases we go towards parenteral iron therapy. Options include iron sucrose, ferric carboxymaltose, and iron dextrin. So coming to the numbers: 100 milligram elemental iron per infusion, that is iron sucrose, 100 milligram elemental iron per infusion. Ferrox carboxymaltose, 1000 milligram per dose. Yeah, and then iron dextrin is IM IV, but it has a risk of anaphylaxis. Coming to blood transfusion, we have seen it already, less than 7 gram per deciliter, signs of decompensation. With signs of decompensation, that is the indication. Packed red blood cells transfusion and exchange transfusion in cases of severe anemia with cardiac failure. And then coming to dietary modifications: increased intake of iron rich foods, meat, fish, poultry, green leafy vegetables, and avoid calcium and tea consumption with meals to enhance iron absorption. So these are the things for dietary modifications. Finally, coming to prophylaxis: all pregnant women should receive 60 milligram elemental iron daily starting from second trimester. Deworming with albendazole in anemic areas to prevent hookworm related anemia, and early antenatal screening and regular hemoglobin monitoring. So these are the things overall, which is very easy right now because you have gone through this lecture, this short video. Yeah, now I'll close this. Yeah, so in case you like this particular video, you can like it. In case you would like to watch more of such videos, you can subscribe. And if you have anything to say about this, or any kind of discussion or anything, you can do it in the comments or the Instagram DMs. Okay, then bye bye.